that we see in, and definitions, you know, are broad and flexible. The activities can really be focused on the development of housing resources. One of the distinctions is that it's not based on individual client placement or steering clients to wait lists and things like that. It is much broader, higher level development of those resources, as well as being able to conduct research and activities that will show you where you really need to put your resources within a community. So I'm going to turn it over to Jake to talk a little bit more about some specifics with that, and then we will come back to talk about needs assessments more. Oh.
So just progressing on the slides, here we break out the two bullets on establishing, coordinating and developing resources, and then conducting research. Under resource identification, we call out 4 types of activities. Again, this is not defined by HUD. This is being defined by us in this room, so it's flexible. Development of housing resources. We'll go into detail for all of these. The next one, systems level coordination. Then the needs assessment and research related to HIV/AIDS housing and services. And then HOPWA training costs. And of course, that's where your program may have used funding for this. You were also given instructions of how else to do this, but Resource ID is one of the sources that can be used for training costs. So if we go to the first category, developing housing assistance resources, the first thing we identify, which would be linked, of course, to the tenant-based rental assistance or even the project-based assistance category, would be the outreach and relationship building with landlords. So here again, we're making a distinction between a systems level activity and a client level activity. So if you had an individual client and you were helping them move into an apartment, what would that be?
Case management.
Yeah, well, specifically, what activity would you charge that against? Permanent housing placement, right? But in this case, we're talking about talking to a number of landlords and trying to build a resource network of landlords that are friendly to us, and so that would be a resource identification activity. And the next one, we're looking at the existing housing resources and vacancies. And so if you're in your community, you kept a roster of the units that are all HOPWA funded and which ones are occupied and which ones are vacant. And if you know a vacancy is coming up, you could alert this central location and stuff. Again, a resource that could be funded under the Resource ID activity. If you're spending time leveraging other resources from the Ryan White program or public housing authorities, the continuum of care, homeless, or whatever, that, again, you're building the community level resource, interfacing with public housing authorities to hopefully expand the acceptance of people with HIV in their waiting lists and programs. And then if you maintain an external website that people can access to get information about housing, that also would be considered a resource identification. There's a parallel here which would be housing information and referral. So if somebody called you or wrote to you and wanted information about what's on your website or elsewhere in the community, if you're interacting one-on-one with a person about information specific to them, that would be information and referral. But if it's the systems level, it would be resource identification. Does that make sense? Any questions about that? Again, this is not a hard definition. This is a working definition. Okay. If you have any specific questions in your community, have a conversation with your grantee. Or if you're a grantee and you want some guidance, send Crystal an AAQ or talk to your field office. Okay. So segueing immediately into system coordination, the first two words here are both verbs. So you can either create collaborative efforts or you can lead collaborative efforts. You can participate in collaborative efforts. So if you meet on a routine basis with your continuum of care for homeless people to talk about increasing access for clients in general, not a case management to case manager, talk about a specific client, that general level activity would be considered systems coordination. If you're trying to coordinate housing case management programs, again, not client level, that would be resource ID. And if you're building a continuum of housing, both HOPWA funded and non-HOPWA funded. Crystal, do you have any, we say other here, I'm going to ask Crystal first to give you guys a chance to think for a second. Other specific system coordination activities that you would call out? Anybody else doing something along these lines? I would say this, that if you're working to build an employment referral system for your clients so that they can get better employment, that would be something that you could build to this. So your grantee would have to establish this category as a as an allowable activity under any project sponsor's grant agreement, and then there would have to be a scope of work developed so that you knew, if you were a project sponsor, you knew what to do. But all of these activities that we're describing are allowable under this activity.
And sometimes it's funded on a system level or either through...
Can you use the mic because they're translating?
Sometimes those kinds of efforts are funded. You can use these kinds of funds as a grantee to add a staff person to be, spearheading these efforts. It can also be through project sponsors to do specific kinds of things for their area or across the whole area. I mean, it's very flexible that way. We've seen it used to bring coalitions together and to hold monthly housing-related meetings and other things that would help develop whatever those needs are locally.
Mm-hmm. Okay. So then the next category is this needs assessment and research. And so we're actually going to spend the bulk of the rest of the meeting on this topic. So here, this is the, everybody has the perennial question of how do we identify what the unmet need is? And how do we make sure that our programs are designed in such a way as to target the needs that our clients are facing, both the ones that we know that they have now, and if we have some degree to look into the future, what we anticipate their needs might be in the future. Because as we all know, especially if you're doing capital development, you have to be thinking 5 years ahead, because that's how long it takes to put up a building. So first thing we do is we start out with looking at the data. What are the data that we already have that are already collected, that are already available to us in the community? And then we can analyze that data. So we have a quantitative data component, but we also want to have a qualitative component. So for that, we look at client surveys, needs assessments, focus groups. That's layered lower down in the list there, where we are actually interacting with clients directly affected, the family members and friends of clients, advocates on behalf of clients. And then we also always want to talk to the providers and see what their perspective is, because oftentimes the clients and the providers have two different approaches to the same problem. And you want to hear both sides or both perspectives, all perspectives, as you're solving these problems. Housing market studies, of course, are important. Oftentimes a community says, well, we want to do a pretty comprehensive assessment, which may require the hiring of a consultant firm or a team of people, a cross-disciplinary team perhaps, to do the assessments. And there may be other activities and expenses associated with this. One thing I would say is ask the question first, how many people here have ever used or looked at the Econ Planning Suite in the HUD website? Okay. So this is the tool that's used to put together the consolidated plan. And in that tool, there are numerous databases of information collected by HUD and the census and others that are available to us just as people who use the web to download and make sense of. For example, you can map all of the buildings that receive assistance, and you can look and compare that to where people go for services. You can use these mapping tools and other data sets to great advantage. And then finally, the last element under resource ID that we're calling out is the HOPWA training costs. So this includes HUD-approved HOPWA trainings, including conferences, meetings, and such that have been authorized by HUD, but also at the grantee level. If you were conducting training to your grantees, you could bill the training time to this category, because you're building the resource, you're building the capacity of the area. And in response to a question that came up Wednesday, if you're training people on how to complete an application, how to complete a caper, or anything related to the standard grant management or financial management functions of the HOPWA program, that would not be a resource ID expense. That would be an admin expense because it's part of the actual admin activity. But if you're training them about expanding the capacity of the services they provide, or to learn about best practices or things like that, where it's related to the services side, then the trainer's time could be billed against the resource ID time. The participants would bill it against whatever they normally bill their time to as a service provider. Except when you get a notice from HUD on the listserv. So if you, I'm not going to make you raise your hands again yet, but if you aren't already signed up for the HOPWA listserv and some of the other very interesting listservs at HUD, I encourage you to go to the HUD Exchange and sign up. There's about 40 different options, and they're very helpful, very well thought out, succinct postings. It's not too much, and it's always interesting. Okay, so any question, whoops, wait a minute. How come it's not moving? There we go. Any questions about the definition of resource ID? Yes, can you just go to the mic?
Yeah. I'm too short for it, though.
Pull it down then, that's fine. We'll ask
I
Andre
asked
to manage
on
it.
the ask a question, but I'll ask verbally too. Can you elaborate on the housing market studies portion, on what exactly that
Sure.
you mean by that?
Sure. So what I can tell you is it's a technical term for HUD, and I don't have the full explanation of the technical term, and you probably don't either, Crystal, right? But well, we can answer it. Go ahead. We can answer it off the hip.
Yeah, I mean, we were using that in a general sense that could relate to the kind of market studies that have to be done as part of the consolidated plan, especially to make sure that you're getting that information for the HOPWA portion of it. But it also relates to more, market studies of what kind of affordable housing units are available for your clients, and an inventory of sort.
How about like fair housing?
Yes, that could certainly be part of it.
Sure.
Sure. The goal of it is to understand what are the dynamics of the housing market currently, and how does that impact the accessibility and the availability of housing for people living with HIV and AIDS, who are, by definition, low income if they're receiving HOPWA assistance. So where I live in Seattle, or some of the other larger cities on the coasts in the US, our rents have doubled in 4 years. That's a big change, right? People are seeing $500 or more a month increases when their leases come up. I mean, it's huge. So that's the kind of thing we're talking about. That makes a really different rental market. Any other questions? Okay, so let's get into the meat of it then on identifying, assessing community needs. So central circle, what are the HIV housing needs in the community? Do we know what they are, and how can we find out? So as we started, so we're going to talk about 3 categories, the first one being the data that's available. What are the data that we have? What do we already know? And what are some of the key elements that we want to consider? So some of these things you'll recognize can come right off of your CAPER data. Some of them you could calculate off of the information that you have on individual clients. Some of them you can rely on market studies or studies done by public housing authorities or outside research firms that report on housing conditions in your area. And then if you subscribe at all to national housing newsletters, you'll see studies coming out all the time from Urban Institute or Harvard or here or there, National Income Housing Coalition, telling you how expensive housing is and what the gap is. All of those are useful because we're all part of a national housing market, and it's all moving in the same direction in general, right? So first thing we want to find out is what are the household incomes. For the purposes of planning, we may want to look at averages, right? Because every individual household is different, but if we know what our average incomes are, that's helpful. The housing cost burden, that's a specific number which is calculated to be the difference between the person's 30% allowance of their household income for rent and the actual market rent. So if you're on Social Security and you're getting $728 a month, the amount that you can pay is 30% of that, which is like what, let's just say $215. and let's say the rent for your apartment is $815 a month, then your housing cost burden, your affordability gap would be $600. Sorry, I moved ahead. And then your housing cost burden would be, if you had to pay more than the $215 a month, you would be burdened. And we'll get more into detail about that. We talked about accessibility and availability of units, and of course geography makes a really big difference, particularly when you think about transportation, both the cost of transportation as well as the availability of transportation in and out for people getting out to services or bringing services in. Of course, it all matters. So as you look at these data, the first thing that you want to do is gather them. And so we say, what is the recent information that you have on your target populations? What do you already have in hand, both qualitative and quantitative? And then what do these data tell you about the housing needs? After this general section, we're going to go on a specific case study. So we'll look at how some of those interpretations were made. And one of the key things we want to understand is how stable are the households that are currently being served by HOPWA, because that's one of the goals of HOPWA, right? Maintain housing stability. We also, of course, want to have an accurate inventory, what's available to our clients, both funded by HOPWA and not funded by HOPWA. And we also want to know, what's the configuration of those units, how many bedrooms, how many bathrooms, what floor are they on, what type of a structure is it, how many of each do we have, are there any other limitations or special features? If some of the units are universal design, or they're adaptable to people using wheelchairs, or have other physical impairments, we want to have all of that. And then we'll look at all of what we have to identify unmet needs and service gaps. In a minute, when we get to that case study, we'll look at Ryan White. One of the cool things about the Ryan White analysis is that even if someone's getting some services, they ask what's the gap beyond what they're getting. They're getting services in a category, is there more that they needed but they weren't able to access, and why? We don't really do that in HOPWA, but it would be an interesting thing to do, to understand, even for the clients that we're serving, where are we falling short in terms of meeting their total need. And then after identifying the needs and gaps, the inventory, and assessing the qualitative and quantitative data, we'll develop some priorities for housing and services. Here are some sources for gathering the data that we would typically refer to, starting out with the data that we already have in-house about all of our clients, both in the aggregate as well as potentially in age group bands, or by gender, or whatever special characteristics might matter to us, the veterans, people with criminal histories. Of course, there's a wealth of data in the APRs, the annual progress reports for the competitives, and the CAPER, comprehensive annual performance and evaluation report for the formulas. We mentioned Ryan White and all their assessment data. The HIV surveillance data for our area, which is managed by the state and maybe by the county, so you can get it at a pretty low level if you want, a pretty small level if you want to. The consolidated plan, which we talked about, as well as the homeless management information system. What communities are using HMIS for data collection for HOPWA? A small proportion, okay. So sometimes it's hard to get the report you want out of HMIS, but they do have the HOPWA data set is available to all the HMIS vendors, and you can use HMIS for HOPWA reporting if you want to. And then, as we mentioned, specific surveys and interviews with clients, and then community level data on housing and poverty, other things like income, other things like that. So having gotten the quantitative data, we also encourage listening sessions and focus groups for client input, as well as provider groups, interviews, focus groups, questionnaires, and even steering committees. In a lot of our planning work, we convene a steering committee and pick a pretty broad level of people who are community leaders and ask them to help us guide the process. They don't need to be involved in the gathering, but they're an important voice to reflect against in the interpretations. And then if they are part of the product, then they have a little buy-in. So when I worked at AIDS Housing of Washington and we did community planning around the country, we often would have at least a local elected official on board, as well as some faith leaders, maybe somebody from a university research team, of course, housing providers, healthcare, maybe fire and emergency. You know, people who have a stake in what happens with people living with HIV/AIDS in the community, because also their names on any report give it some validity among various constituents groups that we might want buy-in from. So there's a small p political angle to this too, that you really want to make sure that you're listening to the right people. Yep. Oh, I'm sorry. I thought I had it up there. I apologize. I like this. I like seeing the socks on the clothesline. This is one of my favorite slides. Okay. So interpreting the data. Hang on. Oops. Wait a minute. I'm managing two things here, and I got out of sync. Okay. So what does the data tell us? So here are some examples. If you have a high housing cost burden, so you're paying a high percentage of your income, and low median incomes, then that means that there's probably a need for rental subsidies because the rents are high and the incomes and percentage of incomes are low. We talked about affordability gap. If the affordability gap is large, we will obviously have the same conclusion. Clients are reporting difficulty finding units in good areas or areas where they feel comfortable. Well, we may need, if that's true, then we may need to develop lists and relationships with landlords in other neighborhoods, in places where people can, in fact, feel safe, and where the units are more likely to pass habitability standards. Geography, of course, has two primary aspects. One is where are the individual units located, but also do we have units or resources available throughout our metropolitan statistical area or throughout our service area? Are people needing to move away from their home base in order to get housing? How are the rents compared, you know, what are the market rents compared to the fair market rents? And how many people are in temporary housing? How many people need to be moved into permanent housing? In terms of interpreting the data, one of the things that we look for is, as a marker, as part of our access to care, is a demonstration that their health condition, the markers for health, are moving in the right direction. If they're in housing, we would expect their health to be stable or improve. So you'll see here the two bars on the left-hand side are at entry, and the two bars on the right-hand side are at exit. The cream-colored or peach-colored bars are the control group, and the blue-colored bars are the people who were accepted into tenant-based rental assistance. And you'll see a dramatic decline. In this case, we're looking at viral loads. The viral loads dropped and stayed low considerably by being in tenant-based rental assistance. This is exactly the outcome we were looking for, and we're happy to demonstrate that it's true. Control group went down a little bit, but not as a result of TBRA and not as dramatically. This table is just, it's a story, right? So there's 6 risk factors on the left-hand column: homelessness, affordability, rent increase, tenure, substance abuse, and mental health. And on the right-hand side are some ideas about what kinds of questions or what you would look to examine these risk factors. So a history of homelessness in the last 6 months would be an indication that they've experienced housing instability. If there's a rent burden of over 30% of a household income, that's an indication that they will presumably be housing unstable. If it's higher than 50%, then it's a severe rent burden. Perceived need to move because of a small increase in rent. In this case, the question was asked if $50 would cause a person to move. If a large number of people said that, again, that's showing some instability in that particular household. If people have only been at a certain address for less than a year or have a history of being at an address for short periods of time, that also would reflect instability, as well as being treated for either substance abuse or mental health issues in the past 6 months or so. Do you want to add something, Crystal? You're good. Okay. You may recall on our list, our next thing was what are our resources, and so how many HOPWA units do we have? If they have wait lists, what are they? How long are the wait lists? How many are on the wait list? How long do they have to wait? What's the turnover rate? the availability and accessibility of affordable units, and what kinds of services are available, and which services are our clients receiving. You'd be surprised, maybe you wouldn't, but you know, even though a referral, an agency is listed as a possible referral on your referral sheet, and even though they, individual clients may be referred over there, if you were to call that agency up and say, how many people with HIV are you seeing? How many of the clients specifically that my agencies have referred to you have you enrolled? You might discover that the number is 0 or very, very low. And if that's true, then a conversation might be necessary to say, well, what happens if I send Jake over there and then Jake doesn't enroll in an agency? Why didn't that warm or cool handoff result in enrollment? And it could be discrimination, it could be fear of disclosure of HIV status, there could be all kinds of things going on. And so in this inventory, we want to make sure that the services that we list are actually services that people are using, not just ones that they could potentially use and are not being utilized, because then if they're not being utilized, they're not actually part of our system, right? Yes?
I changed my mind. Can we go back to the last slide? Can we go backwards? So I want to talk about this a little bit, because this set of 6 factors is something that our agency used in about 4 different community needs assessments looking at HIV/AIDS housing. And one of the primary places we started that was here in Tampa. We came in, gosh, it was probably 11 years ago to do a 2-year project for the city of Tampa. And we developed a client survey related to housing and housing stability and other issues for the 4-county area. But in part of that study, we came up with these 6 factors. These are by no means the only kind of factors that you might include for these kinds of studies, but we feel like they're important ones. We've used them in a variety of communities, and they tell you quite a bit, right? And there are other ways, you know, in addition to or instead of doing an area-wide needs assessment, that you can start to collect or understand this kind of information about the people you're serving. One of the things that, one of the reasons that we ask a number of questions about homelessness is that, I mean, do you all think that the point in time counts accurately reflect the number of people who are HIV positive? No, they don't. We see them as consistently very low, and we know that's not reflecting the folks that are in our community. But when you ask questions like, have you, how many times in the last 6 months have you been without a place to stay? When have you been homeless? You didn't get that history of homelessness. Plus anybody, if you're doing a survey, who is currently homeless. So you've got those 2 things. And what we saw, and we'll talk about a little bit later in those survey results, was that we were more at about 11% of the population in a couple of different areas who had had some experience of homelessness in the last 6 months or the past year, depending on, what that survey was. I think on affordability and rent burden, this is something that you can actually incorporate. Agencies can easily incorporate this in your assessment. When you're doing intake for people, and make it part of what you collect for your client files. Because really what you need is what the household income is, which you are collecting anyway, and how much people are paying for rent and utilities. And you do that calculation of housing rent burden and start to get, that's something we do in STRMU. It's, that gives you kind of a beginning point to say how much on the edge of stability are these folks. If they're paying 75% of their income for rent and utilities, this particular unit might not be the plan for them going forward. So it has multiple benefits. The rent increase question is more of just a quirky question that we came up with for surveys that ask people on a scale from $1 to $25 up to $100, how much would your rent have to increase for you to feel that you'd be forced to have to move somewhere else that was more affordable? And so it's all client self-report. But very interesting results when you look at that. And the other are pretty self-explanatory. But I think there are ways that these could be used. And other measures. I mean, there may be many other measures that you can look at that you might want to collect in your own community.
Absolutely. Thank you. Thanks, Crystal, for adding that detail. I want to say that when we did a lot of surveys at AIDS Housing of Washington in the 1990s and into the 2000s, over 15,000 total. We hired people infected in the communities to go around and do the surveying, and asked a lot of personal questions, including this question. And the only thing I wanted to reflect on was 15 years ago, the answer was more likely to be $100. That would take $100 for them to have to move. And I think it's interesting that now the median amount in the recent studies is $50. It just shows you how much tighter life is for people now, than it was 15 years ago. And we know that because wages have been stagnant for 15 years and inflation hasn't. And benefits haven't gone up that much either, right? Okay, I wanted to, on the resource inventory, I just wanted to say something about wait lists. This is just a practical matter. There's a jurisdiction that I was working with. They have 1,000 people on their waiting list and 5 units of TBRA turning over every year. So the people at 999 are on a 200-year waiting list, and there isn't an HIV medication in the world that's going to keep you alive for 200 years. And the waste of time isn't so great, but the waste of hope and expectation that people are waiting to get on a HOPWA TBRA through 3 lifetimes, it's not a good way to live this life. So if when you do this inventory and analysis, if you discover that your wait list is way longer than reasonable, and you can determine what reasonable is, how many people think a wait list over 5 years is way too long, right? 3 years, 2 years, right? Look at the housing authorities. Now they open them up and they do a lottery. We have to rethink how we manage the waiting list for TBRA, right? Because you don't want to give people the hope that they're going to get something that they're never going to get. That is not a useful use of HOPWA resources. Yes, sir, please use the mic.
So regarding waitlist, when it comes to measuring unmet need, I know just in our jurisdiction, each sub-grantee, not only are we all doing, I think we're all doing waitlist, but we maybe all be doing them differently. So we probably have duplication for one. Is there a best methodology on waitlist? Should it be per grant year, just measure per grant year? I agree that 5 years is too long.
Well, from my perspective, the fact that the wait list doesn't turn over very fast is probably the most important thing, not the number of people who put their name on it, because that's just a random sample of people who thought it was worthwhile to put their name on a list that's 10 or 20 years long. I don't think the wait lists reflect anymore what the actual need is. So I would use the wait list to say you could say, yes, this is what's on it, but more importantly, the turnover is so slow.
Okay.
Right? Because that's the dynamic, is the turnover.
Right.
If it turned over faster, there'd be more people on that list.
Right. And again, like I know we do more of a permanent housing, it's been reiterated over and over again in this institute that it should be permanent. But someone else is transitional, so their wait list turns over faster than ours does, so they're not weighted the same.
Correct. That's right. And so the question there is, for people who are in transitional, how long does it take them to get a permanent unit, right? Just like in the continuum of care.
Okay.
Thank you for asking. Any other comments on the inventory or data sections we've covered up until now? Okay. So now we're going to start blending things, and this is here we have these buckets of paint that we're pouring together here. So on the left-hand side, you'll see the blue-colored line items are the HOPWA-funded housing activities, and the purple-colored line items are the HOPWA-funded service activities, and then beneath them in gray, you'll see leveraged resources, including Ryan White, mental health, and Medicaid services under services, and other mainstream housing under housing. And so what we're going to do now is look at our inventory and put together a picture of our continuum of housing and services. And so this table has 3 columns: quantitative data on the left inventory on the right, and then the client and community input in the middle. And by looking at the elements in these columns and rows in this table taken as a whole, we can deduce what our priorities should be in our community. Knowing that the total quantitative gaps may not be the main driver of how you spend your HOPWA money, because we'll never have enough HOPWA money to meet all the needs in the community. But we want to make sure that our money is well targeted for the outcomes that are our priorities and the priority at HUD. And just a reminder, the 3 priorities for the HOPWA program are housing stability, access to care and services, and then combined, these help to reduce homelessness. Okay. I don't actually have more to say about this table. Crystal, do you or do anybody have a question or comment about the elements of this table? Is everything on that clear to you? Do all the terms mean something actual to you, or are they just words on the page there?
Really, this is just an illustration of, your whatever kind of hard data, your quantitative data that you have, plus any qualitative data from client focus groups, case managers, other things, plus what you know about your inventory. You have to put all those together to have enough information to make decisions about what your priorities will be for funding.
Right, and when you put this on there, you'll probably say, oh, we need to know this, that, and the other thing as well, right? Because we for sure don't know everything we need to know. And the only caveat I would say is that as a planner, I always want to be really clear that if I'm going to ask for an answer, if I'm going to ask someone to answer a question for me, I want to know exactly what I'm going to do with that piece of information once I get it. Because we don't want to be asking people questions just because it's interesting to us. We need to know how we're going to use that information to either establish a priority or a target, right? We want to either make sure it's important or we know where we want to get with it. Okay, so here are a sample of our priorities, right? Under housing, we have these primary categories. Under HOPWA, we've checked them all. We have both TBRA and master leasing as an important element. We have 2 kinds of short-term housing here, emergency shelter. We also have, and short-term housing, we also have facility-based permanent supportive housing. We might, it's not checked here, but we might have project-based rental assistance that's not in supportive housing. That could be here, but in this case, it was not prioritized. And transitional housing, which again is not prioritized here. And of course, the STRMU, short-term rent mortgage and utility assistance, which is a homelessness prevention program. Then on the right-hand side, we have the services that we thought were most important, and that includes housing case management. And remember, every person who receives HOPWA housing assistance needs to have an active housing plan. That planning should start the first day you talk to them, and that planning should be maintained through the end of their tenure with you. As we're trying to increase self-sufficiency and household incomes, employment becomes more and more focused for programs. There may be legal assistance necessary, and the clarification I want to make here is this is housing-related legal assistance. This is not divorce. This is not immigrant status. This is housing-related legal. And then we think that permanent housing placement and resource identification, which are 2 different line items, but they're combined here in one bullet, those are also important in this community for the reasons we described earlier. Okay. Here's another example of the same priorities in a ribbon fashion, and you'll see the 4 types of activities there, and on the left and the right you see the leveraging that is being brought in from outside the community. Some new things here on the right-hand side, we're talking about housing choice vouchers, set-asides, the tenant-based rental assistance of the home program, hard units developed using low-income housing tax credit funding. Maybe there's a community furniture bank. There's some housing counseling that's available for people from HUD. And then on the left-hand side, we have the special shelter units, which maybe are helping people being discharged from hospital. They don't have a place to live, but they need more medical attention than they can get in the regular shelter. We have the rapid rehousing program under the continuum of care. If they're actively homeless, they're not eligible for STRMU, but they would get rapid rehousing. And then, of course, the supplemental services, we have detox, mental health, budgeting and financial management as services that have been identified by clients and providers as being priorities in our community. Take it away, Crystal.
So what this was an illustration of, actually, is if you go back to the last slide,
I can always go back to the last slide.
it's just an illustration of, the decisions you might make about your HOPWA funding, where you want to put your HOPWA funding. And the next one
Yeah.
Relates to your HIV/AIDS housing priorities in the community, because we're bigger than the HOPWA silo, right? We have to take all that into account.
Thank you for clarifying that.
Right,
Mhm.
sure.
Okay, so Crystal, why don't you just stay there because
I'm going to stay here. I'm
you're
getting my
next.
exercise,
Here you
getting
go.
up and
Anyway,
down.
you're next. Here you go. So I'll read this slide and then Crystal's going to take over. So so what's the impact of this planning that we're doing? And so these are some of the questions that we want to answer when we complete our assessment. Are our programs meeting the most critical needs in the community? We will have known that when we compare what we're currently doing to what the needs that are identified are. I guarantee you we're going to fall short in every category to some extent. What are the housing needs being faced by our clients, and what are the most pressing needs that they see? Have we been increasing the housing stability of our clients? Are we wasting money in the sense that, here's an example, if someone comes into you for STRMU every year and you give them 21 weeks every year and then they come back next year and they get 21 weeks and in between they use Ryan White or somebody else's money and they're piecing together a permanency in their housing. Well, that's not the best use of the STRMU program. That's actually, they may have a real need for a shallow rent subsidy, but that's not what STRMU is for. Are we decreasing homelessness, and have we increased access to care? There may be other questions. For those of you who've thought about this either during the last hour or 51 minutes or in the previous years, are there other questions that you sought to answer in your community? Anybody? Yes.
Well,
Just shout it out. Yeah.
one of the big ones for us is actually impact on health. So we look at suppressed viral load.
Suppressed viral load tracking. Yeah.
Right, and
How many people look at health impacts through viral load and other measures? Okay, quite a few. That's
Yeah.
very
That's
good.
great.
Yeah.
we can demonstrate a difference in people that are just attending our Ryan White funded clinics. Our suppressed viral load rate is about 86%.
People at the clinics are 86% viral load suppression.
People who are in the clinics who also access HOPWA are at 88%.
People who also access HOPWA have 5% higher viral load
Yeah.
suppression.
So I mean, for 2 years in a row now.
Fantastic.
we've-
Over 2 years.
We've been looking at this data.
Yeah.
And we just launched TBRA this
Great.
year in
Just
Florida.
launched TBRA in Florida.
So we'll be able to look at 2 different programs now.
Now they can
STRMU
compare
and TBRA.
STRMU and TBRA. Anybody else? That was a great example. Thank you. Okay.
What other kinds of needs assessments are people doing, though? I know you all are. And how are you using data to make decisions about how you're setting up your funding? I know you
Somebody has
are.
to please stand up to the mic and tell us something, okay? One person. Come on.
I'm from Los Angeles, and we run the Information Clearinghouse for HOPWA. And one of the things that we have found that was a huge need were people who had never rented an apartment before. So we do a Housing 101 where we really give training to clients, budgeting, legal services, and then we do mock interviews because many times they had never been in a situation with a landlord. So that's a need that we saw, that individuals had simply never been through the housing process.
Right, and that's awesome. And that led to you actually putting that service in place. If you remember the before and after TBRA group that Jake was showing you with the reduced viral loads for people being on TBRA, that particular client group was almost exclusively homeless before they entered TBRA. And we did a focus group with all of those folks as well. And it was amazing. I sat in on it, and there were 3 or 4 people out of the 10 for whom the unit they were in was the first home of their own they had ever had, the first apartment of their own. So it was really amazing. But all of those folks had to really start, from the bottom up to learn some very, very basic things. So so thank you for that example.
So I'm also from California, San Francisco
Didn't
Bay
you
Area.
help me? Didn't
I
you
did
help
help
me
you yesterday. I ran around with the microphone.
You were absolutely awesome. I was
Oh.
running one of the short sessions by myself, and I had no one else in there. And she ran all over the room with that microphone. So
I enjoyed it
kudos.
because I needed to get up and move after sitting all day.
awesome.
So I'm from Contra Costa County, which is in the East Bay of San Francisco, California. We really need to do a HOPWA needs assessment, but I think I know sort of where like you were talking in Washington, rental prices are ridiculous. There are no units, market, affordable. There are none. So I know what we have been doing, but I don't necessarily know if it's the best. And so we're sort of stuck on how to best use our HOPWA funds when housing in general is absolutely insane in the
Right.
area.
And
So.
I think bear in mind, and Jake, I'm sure you have some input for this, but a needs assessment does so much more than say there are needs. Right? And drills down as much as possible into where are the greatest needs, where could we have the most impact. So that's
Sure. So I'm going to just paint a picture for a second. So the East Bay of San Francisco area has the largest city is the city of Oakland. So Oakland is the grantee, and then Oakland is only in one of the 2 counties. Oakland's in Alameda County, and they also have Contra Costa County. So they split the money and given the money based on historically based on the number of AIDS cases. Contra Costa County gets about 18% or something, and Alameda gets the rest. But it's a pretty divergent amount of money that's.
2017, we're getting about $600,000.
Yeah, okay, $600,000 for this year. So we have done HIV and AIDS planning in the Bay Area 3 times, including Contra Costa County. And the most recent time, we actually did what we called the Omni Plan, where we tried to work with the Alameda County Behavioral Health, the Alameda County Continuum of Care, and then the Ryan White and HOPWA programs to look at how do we develop a comprehensive plan for these jurisdictions. And Contra Costa did not have the same depth of planning, but we did it. So you guys have a plan, you've probably seen it. 5 years old now, yeah. So the thing is, that plan at the time, and many of you may have older plans, or you can look at the consolidated plan in your jurisdiction. There were assumptions that were made, and there were decisions that were made based on the data that was available at that time. So what I would suggest that anybody could do this is take that data and put it in a spreadsheet, whatever it is you have from however many years ago. Look for comparable data from the most current year you can, put that in there, calculate what the difference is. Does that difference appear to be a trend? If that trend is true, what do you think is happening to it? Do you think that trend's going to continue? Is it going to get worse? Is it going to get better? You can also say, well, this data that we have is not so good, and we looked at all or not enough, not that it's not good data, but that it's not enough data. You looked at all those sources. What other data might we look to see? And I would say, first of all, look and see what's already readily available. Call your planning department. You work for the county. What do you have that might be of interest to me? These are the people, these are the conditions, these are the circumstances that we're talking about. Every hospital has to do a 3-year plan. You may not know this, but all the publicly funded hospitals have to do a plan about the needs in their area. They have a lot of information there about the health needs of the community, maybe something about housing. So again, we're about to go into the community example, but just with what you had, what is now, what do you see, go talk to a bunch of people, and you can start intuiting what it is you need to change just without even doing a whole lot of legwork. Then you can say, well, we need to explore this more, because every time we increase TBRA, we're actually making a $20,000 a year commitment, and we only have $600,000. 300 times 20,000 is $600,000, right? So we can't put that many people in TBRA because that would take all of our money. If we can't do that, what else should we do? And then you go down to the next priority and say, well, okay, we've capped TBRA. What's the next priority on our list? What do we really think needs to happen for other people? Not the people who can only benefit from TBRA, but other types of people living with HIV in our community, other household configurations or whatever. And you will never be able to meet the need, but you can segment it and meet a good amount of need within each category.
Great. So what we're going to do, because I know that we're coming to the end of the afternoon and we want to make sure that people come, if you can, please come to the closing, is we're going to go relatively quickly
We
through.
still have a full half hour.
I know, but
Yeah.
doesn't the closing session starts at 3?
No, it starts at 3:30.
Oops, I was wrong.
No, we
Okay,
have a half
we're
hour
not
till-
in
till
as
we're
much of
end.
a hurry.
Yeah.
However, we would love to have more conversation and more questions, just like, what you've done right now.
There's only 10 more slides, so we're fine.
I know. Oh, we'll stretch it out for 2 hours, right? No. So we primarily wanted to talk about the collaboration between HOPWA and Ryan White. And I'm not going to really go into all of this because we know how important collaboration is and how much greater the need is than our resources. HOPWA has really, under HUD and OHH's leadership, focused on engaging in improved community planning on both the national level and promoting it on a local level. They want us to work to improve leveraging of HIV and homeless efforts with other resources, and to improve the way we use information technology to show the results of our programs. As most of you know, Ryan White is one of the programs that HOPWA works most with, or very closely with, and that's one of the reasons that's a major focus of what we're talking about today. So as we go around the country and talk to grantees, grantees tell us that the extent to which there is contact and coordination between the two systems varies quite a bit from one jurisdiction to another. In some cases, the HOPWA grantee is the same as the Ryan White grantee. In some cases, they don't speak at all. When we start to talk about data sharing, we hear from some communities that they can't even get the results of the Ryan White statewide needs assessment, the results or the raw data. You're saying, am I telling the truth?
Oh, no, I believe you, it's just sad.
Yeah, and this is very important information and should be very accessible to all. So that is part of what we wanted to talk about. And I know that Amy Griffin and Harold Phillips were here. Were they here for the earlier sessions as well?
The first one, yeah.
So I think they're very much in favor of making a push on the Ryan White HRSA side to make this happen, because I think all of the HOPWA folks are eager to see that. And so we want to talk about what some of those possibilities are and how it has worked on a local level. But first, this is just an overview of how Ryan White approaches its needs assessments. And the needs assessment steps that they outline in their planning documents includes all of these things: data on HIV cases, the needs of persons in and out of care, the existing services that are available, any service gaps and needs, and so forth. So all of this should sound familiar. It is the set of things that we have already talked about of what should be in a needs assessment. So we're really in very close alignment with what Ryan White is doing. So there are a number of best practices for HOPWA and Ryan White planning. The one is to actually work with Ryan White to add housing or housing stability related questions to those surveys, and that is one of the examples that we're going to talk about. Second is also just sharing that survey with HOPWA grantees for further analysis, because there are things that can be pulled out from the raw data in those surveys that can really benefit HOPWA with better information. Ryan White, I think, should use it and need it as well, but it should be available to both systems. And we hope that there will be more work done to build bridges between the different kinds of data systems that exist between HOPWA and Ryan White. It doesn't help that we use different systems for collecting information.
And different definitions. for
And
the same
different
thing.
definitions, right. So I want to talk about an assessment collaboration example that involves the state of Louisiana Ryan White Part B grantee. And I know Kira was here in an earlier session to talk about that. But this is a case in which the Part B grantee and the Planning Council worked with the grantees and agencies in New Orleans to be able to add a whole set of housing questions to the Ryan White Needs Assessment data. This all happened after Hurricane Katrina. It was a multi-year effort. CSI was involved with that as a TA provider at first, and we were able to get funding from AIDS United and some other local foundations to make that happen. And how many, I should have asked this before, how many Ryan White people are in the room? Great, okay. And some of you do double duty, right?
Great.
So, good. Glad to hear that. So, you know that Ryan White folks are very protective of those surveys very often, because they're long, and we don't want to overload people. They get burned out on filling out surveys, and so you really want to hone in on what is the most important information. So it's not always easy to break into that system, especially if you don't have a close relationship between the two organizations, and if housing is not a real high priority for that particular Ryan White grantee. So those are some of the roadblocks there. But in this case, the Ryan White grantee was very interested in being able to add some of those. And so we were able to come up with a suite or set of housing questions to add to the assessment survey. And it included information like what's shown here on housing type, where people were living right now, what some of their housing history was. We wanted household size, homelessness history, with those couple of questions we talked about earlier, income, rather than collecting it as a range of income. I make between this amount and this amount. We collected the exact income that they said their household had every month. We wanted their household size, how much they paid for rent or mortgage and utility payments, and a number of other questions, mostly that came out of that variations of those 6 elements that we talked about before. So we felt very lucky to be able to add those. So let's talk a little bit about what the results were. It gave Louisiana and New Orleans for the first time information on trends over time, because we did this over 8 years' time with 4 different surveys on housing burden and affordability among people living with HIV. We knew what the client income was and saw the median income going down every year. Information about housing barriers, homelessness history, and housing stability risks. And these are just some examples of the results. Most of this is from 2013. And we found that people were paying, that 60% were paying more than 30 percent of their income for rent and utilities, and 35% were paying more than 50%, so that had a very severe housing burden. Affordable rent based on that average income for people in that needs assessment group was $272 a month. That was what was affordable to them. And the FMR that year for a one-bedroom unit was $755 a month. So it's that kind of information just hits you in the face. You know it intuitively, but when you start to see it coming out with reports like this in real numbers, it really makes a difference. There was trend information over time that showed households with that severe rent burden going up from 26% to 35% of the sample in 2013. On homelessness, we talked about that a little bit earlier. 4% reported as currently homeless while the survey was being done, and 11% had been homeless at least one night during that year. So in comparison to what the point in time study was showing, we could see that this was much higher. And I think also significant were those, and I know the Ryan White planners found this very, very interesting and useful, is the top reported barrier every year was to HIV care, was money to pay for rent. No, it was always at the top. And lack of other resources, as well as fear of disclosure. Those were the top three. Large scale, depending upon the staff you have, the funding you have, but data is power. For any advocacy effort, for any for anything where you're trying to get additional funding, it's one thing to just get up and say, you know what, we've got huge needs in our community, but if you've got data that shows exactly what those needs are, it's just much more powerful and useful. So it's just a matter of starting to look at where you can pull that data and how you can do that. And of course, we started this whole thing out with Resource ID, which is certainly a way to make this happen. So I would